So if you're going to give morphine, you should be prepared to wait 20 minutes. Otherwise, you might as well have not given it. What we're going to be discussing is 4 things that have just really been a peeve that I just want to get off my chest and just vent about things that, you're doing your job day in and day out and you see these things happening and they bug you. So what are these 4 things? Well, number 1 is the Reverse Trendelenburg. What that means is when you put someone's feet up. This is commonly done when someone loses consciousness or they have low blood pressure and you raise their feet from lying with their head here and their feet here, you go like that. There is actually no evidence that this works. It has no medical benefit. We see it all the time when people are like, oh, they've collapsed, they're unconscious, they've fainted, they've had syncope, put their feet up. It has no effect. What it does is quite interesting though. So it was initially invented for organ surgery because it made viewing the organs easier. And the other thing that it does is that if someone is hypovolemic and you raise their feet, you will have a transient increase of blood pressure. And this is a way to assess someone's fluid. So if they have a low fluid volume and you raise their feet up and you test their blood pressure will increase and then it will drop. And that's pretty much what the science is saying. I'll drop a link to the bottom. It's very interesting. So if someone has lost blood or lost fluid or dehydrated, check their blood pressure, raise their feet, check their blood pressure. If it is higher after you have raised the feet, they are hypovolemic. But their blood pressure doesn't stay up because what happens is that their body then gets used to all the fluid and then it dilates because of the excess fluid or excess pressure because, like the baroreceptors in the neck and in the heart, it then drops, kind of like when you do a modified Valsalva maneuver, which I'll talk about in another channel, or another video, hopefully, same channel. And that then makes the body relax and the blood pressure drops again. So it actually doesn't increase perfusion in any way. Number 1 off my chest. The other one is C-collars or cervical collars. You see people putting these on and then they walk to the ambulance or whatever it is, or they see them on a bed and they're just wearing a collar. This does not stop the patient from moving their neck. So it doesn't stop them from moving their neck. When we put it on, we manipulate their neck more than they would have ever done anyway. And there is no evidence that it actually does anything. And in the booklet that comes with every neck collar, it says this is not designed for use in any emergency situation. It's not even designed to do what we use it for. I'll drop some links to the bottom about why we should not be using C-collars. The other adverse effects of wearing a C-collar is that it makes breathing harder, it makes intubation harder, it decreases the venous return, and it just does nothing good. So really, C-collars, we can throw them out with the spinal boards. No need, unless you're getting someone out of a car. The third peeve that really gets to me is that people give medication and then they assume it works immediately. So this is really important because sometimes it's funny to watch, but sometimes it's really not. So if someone's having a seizure and we give them like 5 or 10 milligrams of diazepam and the seizure stops the moment we give the drug, it was obviously not the drug that made the seizure stop. Just because you did something doesn't mean that that was the fix or the cure. Drugs take time to work. They have onset of action. They have all these numbers that come along with them that we learned when we were students, but we forget them the moment we finish because we have a patient having a seizure. We push the diazepam and the moment we finish pushing, the seizure stops. And we're like, oh, it worked. You see, right thing to do. Drugs take time. The place where this is not good is when we do with pain, when we're dealing with analgesia. So we get to scene, patient has a broken leg, we give them 6-7 milligrams of morphine, and by the time we've finished pushing the syringe, we go, all right, let's move the broken femur. And we think that that's how the drug works. Morphine has an onset time of 20 minutes. So it can start working in like 2 to 3 minutes, but its full onset of action is 15 to 20 minutes. I've had scenes where you get there, guy has a broken leg, the crew on scene gives 10 milligrams of morphine, and once they've finished giving it, they wrap up the broken tib fib and they go in the ambulance, and by the time they've left scene, it's 20 minutes. That morphine had no effect. We must not delude ourselves thinking that giving morphine and then moving the patient is how this works. We need to give the medication time to work. If you're going to do an RSI, we count down for 30 seconds. Why? Well, because the medication takes time. Only once it's fully working are we ready to now look at the airway and past the tube. Because if we go in too soon, it causes a delay, we can't see, the muscles are still relaxing, we stop ventilating, all those things, and so now we count down 60 seconds for an RSI once we're given our meds. Kind of putting all together. The final peeve that I want to get off my chest is fluid in trauma. Guys, Ringer's lactate, saline, which is dirty seawater, bowel salts, or whatever you want to call it, anything that cannot carry oxygen is not helping. I'll drop links to the bottom about how fluid in pre-hospital trauma has almost no place. It almost just causes damage. It makes the patient cold. It dilutes their clotting factors. It dilutes their hemoglobin. Can you see any benefit in this? It blows clots because we're increasing blood pressures. We can let patients have a low blood pressure, a permissive hypertension. If we can feel their radial pulse, they have enough blood pressure to perfuse their kidneys, lungs, and brain. We let them sit there and we take them to hospital. Giving them cold seawater, dirty seawater, is not going to fix the problem. They need hospital. They need theater. The two things in theater that surgeons struggle with is temperature and blood loss. What you need to be careful with when you're giving fluids is that you're damaging both of those things. You're diluting their blood, which has no benefit, and you're making them cold, which has no benefit. It's difficult to raise someone's temperature just by 1 degree. It takes time and effort. So just be really careful. I'll drop some interesting articles at the bottom about how fluid in the pre-hospital setting just has very limited space because it really has little benefit, and oftentimes you get to scene, they put a bilateral liter Ringer's lactate and they're pouring them in because this guy has a broken leg or has a gunshot chest or whatever the case is. It's not. We should be getting patients to hospital. Time on scene is critical unless you're going to be like doing a decompression, or you're going to be doing CPR, or you're going to be doing intubation because the patient is not breathing. Those are like critical interventions. But putting up a line and giving dirty seawater is not a critical intervention. Thanks guys for letting me get this off my chest. It's just, let me know if you guys have anything that you see when you're in hospital or on scene or wherever you guys work. I would love to know where you guys do work and where you're from. But I'd love to know things that you see that you're like, why are you doing that? Please don't do that. So I know it was a bit of a strange video, but I appreciate you for watching. I know you guys, those guys who hit that thumbs up, you're the best. You are incredible. So thank you for watching and have a nice day. Bye for now.